Hello, and welcome to the Diabetes eJournal Club. Our moderator is Dr. Frank Svec, clinical professor of medicine at Tulane University School of Medicine and attending physician in the endocrine clinics at the Medical Center of Louisiana at New Orleans, Louisiana. Our discussant today is Rena R. Wing, Ph.D., professor of psychiatry and human behavior at the Warren Alpert Medical School of Brown University and director of the Weight Control and Diabetes Research Center at the Miriam Hospital, Providence, Rhode Island. This 30 to 60-minute audio program, combined with the online programming, is directed to endocrinologists, primary care physicians, internists, and other healthcare professionals who manage and treat patients with type 2 diabetes mellitus. DIME is accredited by the Accreditation Council for continuing medical education to provide continuing medical education for physicians. If you're interested in obtaining CME CE credit for this session, please complete the post-test and evaluation that will appear on the screen when the session concludes. Your statement of credit will be available for download as soon as you have met the CME CE requirements. This activity is supported by an educational grant from Amylin Pharmaceuticals Incorporated and Lilly USA LLC. You can ask a question at any time during the presentation using the Ask a Question box on the website. Click in the open area, type your question, then click the Ask Question button to submit. If you need technical assistance, please type your inquiry into the tech support box on the left side of your screen and then click Send. If you're disconnected from the webcast, you can log on again using the instructions provided to you for accessing this presentation. If you're unable to log back on with these instructions, please call 877-843-9272 and ask for assistance from one of our technical support representatives. It is now my pleasure to turn the webcast over to your moderator. Dr. Svec, the floor is yours.
Well, thank you very much, and welcome to everyone at our inaugural issue here of eJournal Diabetes Metabolism. And I think we have a very interesting paper to discuss today, certainly a very critical one I've been excited to read, and we're very fortunate in having one of the investigators with us today, Dr. Wing. And Dr. Wing, I'd like to welcome you to the journal today.
Thank you.
Well, we're going to go through this. This is a very important project, obviously. Let me tell you, as an endocrinologist, we always say the first thing in treating diabetes is diet and exercise, and we say this with great certainty. But the trouble is, it turns out we've never really explored this. Is it possible? Does it help? So I think this paper we're going to be talking about today, which was published in the Archives of Internal Medicine just last year, and I think on your screen you could see the journal quote there, so you get a chance to see where it is. We're going to address that question here with a large study that was done trying to ask the question, does diet and exercise actually make a difference in diabetes? Can we do something about it? As I'm advancing the slides here, and you could see that if you're one of the participants listening in live online today, you could ask a question at any time, type it in, I'll take a look at it. We might answer some as we go along, or we'll save them towards the end. But let's go to our first question, or first slide of the presentation, where we're going to be talking about learning objectives. We're going to be trying to get people to identify strategies that reduce the risk of cardiovascular disease in those patients who are overweight or obese and have type 2 diabetes mellitus. And we're going to look at the effects of this in the study where it was done, the cumulative effects of intensive lifestyle intervention versus what will be customary diabetes support on glucose levels, cardiovascular disease risk factors in these patients. And then we're going to be at the end, hopefully a person will have some better idea of effective and realistic lifestyle-based changes they could institute in their patients in their clinic today. So let's get to the introduction. It's kind of interesting, as I've said, we know that cardiovascular disease risk factors are something that we should prevent and reduce in patients with type 2 diabetes, because type 2 diabetes, the most common problem that people face at the end is cardiovascular disease. So we're screening for these and trying to manage these much more than ever before. And the first thing we always do, since most of our patients who are diabetic are overweight or or obese, we institute lifestyle-based weight loss interventions because we feel that's the cornerstone of reducing glycemic control. And it's been shown, too, that these things do have favorable effects. But the trouble is, just about all the studies done up to date are only of duration of less than 1 year. We know they work within 1 year, but what if you continue on along? Do they continue to work? So what we were looking at with recent improvements in behavior therapy, and our speakers, our discussant is going to be an expert in that area, what changes we can actually institute with patients. How do these things work in long-term applications? Because proof that these interventions lead to long-term improvements has been lacking, not yet been published, and now we're going to start to look into it. So we're going to be examining some of the longer-term effects of these interventions on glycemic controls in this paper, cardiovascular risk patients, in those patients who are overweight or obese and have type 2 diabetes. Now, in particular, we're going to be looking at what's called the Look Ahead trial, and it's a multidisciplinary lifestyle intervention trial. And maybe this is a point where I could bring Dr. Wing in there just to tell us a little bit about it and maybe comment on the slide that's on the screen about this study. Dr. Wing.
Thank you. The Look Ahead trial is actually going to be going on for a total of 13 years because our interest is really to find out whether an intensive lifestyle intervention will actually reduce the risk of cardiovascular morbidity or mortality. So we're going to continue following these individuals long term. But we felt it was important as we were doing the study to stop at certain points and publish. First of all, we published already how our results were at 1 year. And now in this paper, we're publishing what we found at 4 years. So partway along the path of this very long-term study.
Excellent. And I see it's a very big study. So we have on the bullet point there, we're talking about 5,000 patients. This is no small study by any means. Over 5,000 patients are going to be divided into this randomized study. And let's see, the participants, because it was a big study, 16 centers in the United States I see you used. Ages were 45 to 76 at the beginning and then moved up to 55 to 70. Why were they moved up to 55 to 76, by the way? What was the thought behind that?
Well, in order to do a trial like this and see if you really are able to reduce cardiovascular disease events, you need to be identifying a group of people with a high risk of having cardiovascular events within the next 13 years.
I see.
And when we first started the study, our people were coming in a little too young and a little too healthy. And so it would have taken more years of the trial. So we moved it up to the older age group, too.
Interesting. But that's going to be an important thing we could talk about towards the end of the presentation is when should you, when should we interfere with a patient or intervene with a patient? Maybe the earlier is better. So we're going to see how this applies. And as I see there, the way we decide, or the way you decided was a diabetic patient that were self-reported or by the medicines they were using. And you did have the standard criteria that if your BMI was over 25 for one of your indications, that's overweight. But if they're receiving insulin a little bit heavier, hemoglobin A1C had to have be less than 11%. You don't want people way out of control. Blood pressure had to be in certain limits so they weren't too far out of control. Triglycerides in some degree. So it would be ethical to put these people in the study there. And approximately equal numbers of people should be taken into the study. And I see you had a very interesting thing. You tried to get different racial and minority groups there.
Well, yes, as many probably know, type 2 diabetes disproportionately affects minority members.
Yes.
And so we wanted to make sure that people from minority groups were represented in our study to see if it would help those individuals.
Yes, I think that's very important to get into our study, right. Participants were required to have a successful graded treadmill test, 2 weeks of self-monitoring, and attend these educational programs, which I think is interesting. I'm going to talk a little bit more about the treadmill testing before. Then the interventions, and they were assigned to either an intensive lifestyle intervention or a more routine. Tell us a little bit more about that, what the intensive lifestyle intervention actually meant.
Well, we designed this intervention to utilize the best of our state-of-the-art approaches. So we wanted to maximize the chances of showing good weight loss and good outcomes. So the intensive intervention involved both changing people's diet and their physical activity. We asked everybody to try to achieve at least a 10% weight loss, but for the group as a whole, we were really aiming for a 7% weight loss. We gave everybody in the intensive lifestyle intervention a calorie goal. Asked them to eat between 1,200 and 1,800 calories a day, depending on their initial body weight. And we recommended a low-fat diet with less than 30% of calories from fat, since our interest really is to prevent cardiovascular heart disease. What we did at times during the program to increase dietary adherence, we actually provided participants in Look Ahead with liquid meal replacement products, because we know from previous studies that having a liquid meal replacement like a Slim Fast or a Glucerna, those type of products can really help people adhere to the calorie goal. So our main interest was to give people a calorie goal and then produce as strong adherence to that as possible.
And did you actually provide meals? I see it's portion controlled, but did you just tell them about it, or did you ship meals to them?
No, we did not provide meals. The only thing we provided was the liquid meal replacements, which they began by using for 2 meals a day. So, for example, breakfast and lunch might be a liquid meal, and then they would have their regular snacks and a healthy dinner.
Excellent. So this is something a physician could institute at home, actually, or
Absolutely.
with their patients. Okay. And the exercise, how did that
Exercise was done by participants at home, and we really focused on walking because we feel that that's most appropriate for an overweight, older, type 2 diabetic population. And we asked them to gradually increase their walking until they were doing 175 minutes of physical activity per week, or about 35 minutes every day of the week.
And would they journal this and report this?
They journaled both their eating and their physical activity.
And I think that's probably got a lot to do with compliance, because when a person starts writing it down, it does make a difference.
I agree with you, and that, again, is a key strategy that clinicians could use in their own offices, asking patients to write down their eating and their exercise.
Yes, and so I see now other things you use, behavioral strategies, self-monitoring, goal-setting, problem-solving were used. But what about the standard group, the standard educational group? Tell us a little bit about that.
Well, the Diabetes Support and Education Group attended 3 meetings each year. One focused on diet, one on physical activity, and the third was primarily for social support. At those meetings, we did not present behavioral strategies, and we did not weigh the participants, but we were staying in close contact with them through those educational sessions.
So I think I thought when I saw this is important, because this will be very much like what, I hate to say routine, but it's somewhat routine. This would be the routine way that a diabetic would be taken care of. So I think this is important because it's realistic, and second, the patients were being treated, even in this, I don't want to call them a control group, but the other group, the Diabetes Education Group, they were being treated too in a fairly customary manner. So
one of the important points on this slide that I just want to emphasize is that all participants in Look Ahead continue to receive all of their medical care from their own physician.
Yes.
We did not make changes in their diabetes medication or their lipid medications or their hypertensive medication. We allowed the physician to do that as they chose. The only exception to that was very early on in the program, where people were losing weight quite quickly. We did adjust their diabetes medication following a standard protocol. But we then moved off of that and allowed the physician, the participant's own physician, to make all subsequent adjustments. It's going to be important in interpreting the results later.
I think so, yes. So let's see now. When we really get to it, the frequency of interventions. The first year, your patients were seen weekly for 6 months, then 3 times. That's the intensive lifestyle intervention. During the subsequent years, they were seen individually at least once a month. I think all this contact has a lot to do with it. There was a very interesting article in today's paper that was saying, I thought very interestingly, that over 50% of overweight patients claim that their doctor never told them they had a problem with their weight. So I think the contact makes a difference, because what they mentioned, at least in the newspaper article today, is that those people who are involved in it, told that this is a problem, much more likely to adhere to a program. And so at each session, the patients were weighed, self-monitoring records were reviewed. So they were really involved in their care. Dr. Wing, is that true?
Absolutely. And as you say, contact is critical.
So this is something, once again, that a person could do in their office with their patients. It's nothing tremendously difficult there. But the other ones were invited to 3 group sessions, and as you've already mentioned about that, and the groups attend the sessions on different days, which is also very important so they don't start talking to each other, so there's no crosstalk there.